Let's begin. Hello everyone. Welcome back to the series of lectures in endocrinology. So till now we have discussed about the pituitary, the thyroid and the adrenal gland. Now we will be moving on to a very important topic, which is your diabetes mellitus. So India is the diabetic capital of the world, so we will have to know in and out about diabetes mellitus. So in today's session we will be learning about the diagnosis, the classification and the pathophysiology of diabetes mellitus. Okay, so let's begin. So what is diabetes mellitus? So diabetes mellitus is basically defined as a group of disorders of carbohydrate metabolism which is characterized by hyperglycemia secondary to absolute insulin deficiency or insulin resistance. Okay, so let us look at this definition word by word. So basic funda of diabetes mellitus is that there is increased blood glucose. So there is increased blood glucose. So what happens here? There is increased blood glucose or there is an impairment in the carbohydrate metabolism, which is because of what? Because of absolute insulin deficiency or resistance to the insulin action, which we call as insulin resistance. Okay, fine. So diabetes mellitus is a disorder of carbohydrate metabolism characterized by hyperglycemia. Hyperglycemia is nothing but your increased blood glucose levels secondary to absolute or a relative insulin deficiency. So let us look at the classical symptoms of diabetes. Okay, so before we understand the classical symptoms, let us understand a little bit more about this molecule glucose. So this glucose, when it is present in the blood, you do not find glucose in the urine when the normal blood glucose levels are there. That means that if the glucose levels in the blood are normal, you do not find any glucose urea. There is no glucose urea. But when the glucose levels in the blood increases to more than 180 milligram per deciliter, when the glucose levels in the blood increases to more than 180 milligrams per deciliter, then what happens? Let us look at this. This is the nephron of your kidney. Okay, so this is the nephron and this is the collecting duct. So when the glucose levels in the blood increase to more than 180 milligrams per deciliter, then it crosses what we call as the renal threshold and the glucose begins to get excreted in the urine. So it crosses what we call as the renal threshold and it begins to get excreted in the urine. Okay, so glucose urea is seen whenever there is increase in the blood glucose levels to more than 180. Now, when glucose comes out in the urine, what it does is it draws water along with it and it results in osmotic diuresis. It draws water along with it and it results in osmotic diuresis. Okay, that is the reason why you have the classical symptoms of polyuria and polydipsia which you see in your diabetes mellitus. So you have polyuria and polydipsia which you see in your diabetes mellitus because once the glucose is excreted, along with that water is also excreted. Okay, fine. And apart from this, you can have weight loss and fatigue. So most of the time, patients with diabetes are asymptomatic or they do not give much of importance to these symptoms. The earliest signs are polyuria, polydipsia and weight loss and fatigue, and these symptoms may be there or may not be there when the patient presents to you. Okay, so these are about the classical symptoms for diabetes. Now, let us understand the crux of the matter. We will understand the regulation of glucose synthesis before we understand the defect which is seen in your diabetes. So the most important molecule that there is a problem with in your diabetes mellitus is glucose. So glucose is an energy giving molecule. So the glucose is an energy giving molecule, and where is it obtained from? It is obtained from your food. Okay. So whenever you eat food, whenever you have your food, you have surge in the glucose levels in the body. So this is in your fed state. Now what happens in the fasting state? What happens in the fasting state? For example, when you get up in the morning, you have not had food for nearly 8 to 10 hours. So you are fasting for 8 to 10 hours. So that time you do need glucose in the body for the normal functioning, right? So in that time, if glucose is not obtained from food, where is glucose produced from? It is produced from the liver. It is produced from the liver by the process which we call as glycogenolysis or gluconeogenesis. Okay, so this glucose is obtained by production from the liver by glycogenolysis or gluconeogenesis. Okay, so this is how glucose is maintained in the body. Okay, now what are the functions of glucose? Glucose basically is required by the brain for the normal functioning of the brain. Glucose is a substrate for the formation of fat in the adipocytes. So glucose is basically a substrate for the formation of triglycerides in the adipocytes. Glucose which is present in the blood can be taken up by the muscle for protein synthesis or muscle for action of its actions. Okay, fine. So this is about how glucose is utilized. But this glucose utilization in the periphery is brought about by what? It is brought about by this hormone which we call as insulin. This hormone which we call as insulin. So insulin is a hormone which is produced from the pancreas which improves or increases your glucose uptake. So main aim of insulin is it helps in the peripheral utilization of glucose. It ensures that the glucose is not left behind in the blood and decreases the blood glucose levels. It decreases the blood glucose level. That is the net effect of the action of insulin. So how does it bring about these processes? So insulin promotes triglyceride formation in the adipose tissue. Then it promotes glycogen synthesis and protein synthesis in the muscle. Then it promotes glycogen synthesis and glycolysis in the liver as well. So if this glucose is done with its peripheral actions on the muscle, brain, adipose, then the extra glucose is going back to the liver to be stored as glycogen. And all of these processes is brought about by which hormone? By your insulin. Okay. So whenever there is an insulin deficiency, what do we do? So whenever there is an insulin deficiency, the blood glucose levels will increase. The blood glucose levels will increase. So this is about how your glucose levels are regulated in the body. Now let us move forward. Okay. So now let us understand how this molecule insulin is produced and how this insulin acts. Okay. So insulin is basically a molecule produced from where? It is produced from the beta cells of the islet of Langerhans of the pancreas. So where is insulin produced from? Insulin is produced from the beta cells of the islet of Langerhans of the pancreas. Okay, fine. So how is this synthesized? Insulin is produced from the insulin gene. The insulin gene produces an mRNA which gets translated into an mRNA. The mRNA gets translated into the proteins, and the first protein which is formed is your pre-proinsulin. The first protein which is formed is your pre-proinsulin, which has 86 amino acids, and this pre-proinsulin is produced in your endoplasmic reticulum. It is produced in your endoplasmic reticulum. So this pre-proinsulin has what components? It has a signal peptide, a B chain, a C peptide and an A chain. Signal peptide, B chain, C peptide and an A chain. Now this pre-proinsulin, it undergoes further processing, and in the endoplasmic reticulum it results in the formation of a proinsulin. So how is the proinsulin formed? There is removal of this signal peptide. So the signal peptide is removed and you have your A chain, B chain and your C peptide to form your proinsulin. So the first protein that is produced is your pre-proinsulin. It undergoes further transformation to form proinsulin. So from the endoplasmic reticulum, it undergoes further processing in the Golgi apparatus and it is released. So this proinsulin is released from your Golgi apparatus and it undergoes further processing to form your insulin. Okay. So what is the final structure of insulin? The insulin comprises of the A chain and the B chain, and the C peptide is also removed from that. So the conversion of proinsulin into your insulin is brought about by means of an enzyme that we call as your prohormone convertase PC1 and PC2. Okay. So the final insulin basically comprises of only two chains, A chain and the B chain, and the C peptide is removed from that. Now this A chain comprises of 21 amino acids and the B chain comprises of 30 amino acids. And the final structure of insulin, it is basically connected. The A chain and B chain are connected by means of disulfide bonds. Okay, so the A chain and B chain are connected by means of disulfide bonds, and these disulfide bonds are present between the interchain, so A and B chain. You also have an intra-chain disulfide bond, which is a disulfide bond which is present within the A chain. So the disulfide bond which is present within the A chain is your intra-chain disulfide bond. Okay, so the final structure of insulin is basically comprising of two chains, A and B chain, connected by disulfide bonds. So this is about how your insulin is synthesized. Pre-proinsulin converted into proinsulin, which is converted into insulin. Now once this insulin is released, it is stored in the form of vesicles within the beta cell. So when the stimulus is there to release the insulin, then they undergo exocytosis and the vesicles release the insulin into the blood. So this insulin is packaged and stored in the form of vesicles, and it is released into the blood when the appropriate stimulus is present. Fine? Okay. Now let us understand the mechanisms of insulin secretion. So how is this insulin secreted at the level of a molecular level? So this is your beta cell. This is your beta cell. So first step is that this basic stimulus for the production of insulin is which molecule? It is your glucose molecule. So whenever there is an increase in your blood or your plasma glucose levels, your glucose molecules are the ones which are going to act as the stimulus for your insulin release in the beta cell. These glucose molecules basically go and bind to receptors in the beta cells, which is your GLUT1 and GLUT2 receptor. Okay. Once the glucose enters, it undergoes a set of reactions. So glucose is converted into glucose 6-phosphate by your glucokinase, and glucose 6-phosphate is converted into pyruvate, and in this process it releases ATP. So the first step is the entry of glucose. The second step is this reactions that are happening within the beta cells. Glucose convert glucose 6-phosphate convert pyruvate, and ATP is produced. Third step is that ATP goes and binds to a very, very important potassium channel. Okay, it goes and binds to an ATP sensitive potassium channel on the ATP binding site. This potassium channel is present on the membrane of the beta cell. It is present on the beta cell membrane. So this is your potassium channel, and what happens? It blocks the entry of the potassium into the cell. So once that happens, it causes depolarization. It causes depolarization of the beta cell membrane. So this causes depolarization of the beta cell membrane. So when there is depolarization, the next step is that it causes stimulation of another channel on the beta cell membrane, which is your voltage dependent, calcium ion channel. Okay. So once the ATPase goes and binds to your potassium channel, it causes depolarization of the beta cell membrane, then it causes stimulation of your voltage dependent calcium channel. Now once the voltage dependent calcium channel is stimulated, the calcium ions enter and they act via your CAMP pathway. And then they stimulate your insulin vesicles, right? They are stored in the vesicles. It causes stimulation of the vesicles to undergo exocytosis and insulin release. Okay, fine. So this is very, very clear. So the first step is your glucose entry. Then glucose is acted upon by series of reactions, glucose 6-phosphate, pyruvate, and ATP is generated. ATP acts on your ATP sensitive potassium ion channel, and this causes depolarization of the beta cell. Depolarization of the beta cell causes activation of your voltage dependent calcium ion channel and calcium entry into the cell. Calcium acts via your CAMP pathway and causes exocytosis. So this is about how your insulin is secreted on a molecular level. Now there are two important receptors which are present here. One is this incretin receptor. Okay. So incretin basically stands for insulin secretion. So incretin receptor, whenever molecules bind to the incretin receptor, this is going to again promote your insulin secretion. So what are those molecules which basically stimulate your incretin receptor? They are your GLP and GIP. GLP is your glucagon like polypeptide, and GIP is your glucose dependent insulinotropic peptide. So when GLP and GIP bind to the incretin, they are going to cause stimulation of your insulin release. So why is it important? We know that there are a group of drugs which we call as the GLP-GIP analogs, which are used in the treatment of diabetes because of their action on incretin. Okay. Another very important point is that this ATP sensitive potassium ion channel has a sulfonyl urea binding site. It also has a sulfonyl urea binding site. So sulfonyl ureas, which is another group of anti-diabetic drugs, basically again act via the same mechanism. They basically act as insulin secretagogues. They bind to this ATP sensitive potassium ion channel and they basically cause depolarization of the beta cell membrane and insulin release. Okay. So this is about the molecular mechanism of insulin secretion. Now why is this important? Because any of this, if it is affected, it can result in neonatal diabetes or genetic forms of diabetes like your MODY. Okay. For example, this potassium ion channel has a subunit like KIR 6.4. If that is affected, you can have neonatal diabetes. Similarly, if glucokinase enzyme is affected, then you can have maturity onset diabetes of the young. We will be looking at all of this in detail. As of now, what you have to understand is that if any of this is damaged, you can have neonatal or genetic forms of diabetes. Clear? So this is about your insulin biosynthesis and insulin secretion. Now let us move ahead. Now that we have understood about all your basics with respect to diabetes, let us understand the definition of diabetes. Okay? So what is normal glucose tolerance? So normally the body is in a state of glucose tolerance. So normally the fasting blood glucose is around, let's say, 100. And if the fasting blood glucose is less than 100, we consider it to be normal. Then if the HbA1c is your glycated hemoglobin values. Okay, glycated hemoglobin values less than 5.6% and 2-hour postprandial. Post-PG is your postprandial glucose less than 140. So this is what we call as normal. Fasting glucose less than 100, 2-hour postprandial less than 140. Okay. Then this goes into a stage of pre-diabetes. This goes into a stage of pre-diabetes or impaired fasting glucose or impaired glucose tolerance. So in your pre-diabetes, the fasting glucose is between 100 to 125 milligrams per deciliter. The 2-hour postprandial glucose is 140 to 190 milligrams per deciliter, and HbA1c is 5.7 to 6.4. HbA1c is basically your glycated hemoglobin and it basically represents your 3-month average glucose in the past 3 months. So HbA1c is basically helpful in the diagnosis of diabetes. Fine. So if HbA1c is between 5.7 to 6.4, FPG is between 100 to 125 and 2-hour postprandial is between 140 to 199, then we call it as pre-diabetes or impaired glucose tolerance. When do you call it diabetes mellitus? When there are symptoms of diabetes and random blood glucose more than 200, random blood glucose more than 200 or fasting blood glucose more than 126 or HbA1c more than 6.5 or your postprandial blood glucose is more than 200. So any of these is considered as frank diabetes mellitus. So symptoms of diabetes is present. Fasting is more than 126. Postprandial is more than 200. Okay, postprandial is more than 200 and your HbA1c is more than 6.5. So this is about the definition of diabetes mellitus. Fine. Now let's move forward. So let us come to the etiological classification of diabetes. What you would be aware of is that diabetes is classified as type 1 and type 2 diabetes. But as you can see from the list, there is a whole list of etiological classifications of diabetes. Okay, so the first type is your type 1 diabetes. Okay, so your first type is your type 1 diabetes. In your type 1 diabetes, there is an immune mediated beta cell destruction. Okay, so there is an absolute insulin deficiency. The beta cells are destroyed by some immunological process, and hence there is no insulin at all. There is a complete insulin deficiency. Okay, now what is type 2 diabetes? Type 2 diabetes is when there is resistance to insulin action. So the insulin is not able to act on the insulin receptors, and hence there is a relative insulin deficiency. Okay, so the major forms of diabetes is your type 1 and type 2. Type 1 has an absolute insulin deficiency where there is a autoimmune destruction of the beta cells and there is no insulin produced at all. In your type 2, there is a relative insulin deficiency because of insulin resistance. Let us look at the other types of diabetes. Okay, so first we have your monogenic diabetes. We have your monogenic diabetes. Monogenic diabetes, mainly we have your maturity onset diabetes of the young. So MODY refers to maturity onset diabetes of young. Okay, so the main point in MODY is that there is a problem where there is a genetic mutation and it's often monogenic. So salient features of MODY is that it usually happens at less than 25 years of age. So diabetes happening at less than 25 years of age with a multi-generational family history. There is a multi-generational family history. Okay, so that is your monogenic diabetes or MODY. And this occurs due to genetic mutations in a whole lot of factors. These all factors we will be looking at again, so I am not listing it out now. All you have to know is that there is multi-generational history and diabetes arising less than 25 years of age. Okay, so with this I would like to emphasize that we have a common understanding that type 1 diabetes is diabetes of the young, type 2 diabetes is diabetes of the old, which is not so. So you have to know that even MODY can occur at young age, and the basic difference between type 1 and type 2 is your pathogenesis. It is not about the age. So many a times now that we are seeing with a lot of lifestyle issues, type 2 diabetes is also seen in individuals less than 30 years of age. Okay, fine. Then the next type is your transient neonatal diabetes. Then what are the other causes for diabetes? We know that the insulin is produced from the pancreas. So any disorder of the pancreas where there is damage to the exocrine glands, there is a problem with the release of the insulin. So this can cause pancreatic diabetes, what we call as pancreatic diabetes. Okay, this is your pancreatic diabetes. Okay, pancreatic diabetes is your type 3C diabetes. So what are the causes for pancreatic diabetes? Pancreatectomy, neoplasia, cystic fibrosis, hemochromatosis, and then mutations with some enzymes in the pancreas can result in pancreatic diabetes. Okay, so we have understood type 1, we have understood type 2, what is MODY and pancreatic diabetes. Then there are certain syndromes where there is a genetic defect in your insulin action, what we call as your insulin resistance syndromes. Okay, so we know that insulin resistance is a part of type 2 diabetes, but there are certain inherited genetic defects by which you can have insulin resistance. Insulin is not able to act. Those genetic problems include type A insulin resistance, leprechanism, Rapson-Mendenhall syndromes, lipodystrophy syndromes. You should just be aware of the names. Then endocrinopathies. Very, very important is your endocrinopathies. So other endocrine disorders can, apart from your problem with insulin or pancreas, other endocrine disorders can also result in diabetes, and this is what we call as endocrinopathies like acromegaly, Cushing's, glucagonoma, which is a glucagon secreting tumor, pheochromocytoma. I told you pheochromocytoma has anti-insulin action, hyperthyroidism, aldosterone excess, aldosteronoma. All of these can cause diabetes. Because all of these can cause a problem with the insulin function, insulin resistance. Okay. Then drugs that cause diabetes, very, very important, glucocorticoids. Then calcineurin inhibitors, then nicotinic acid, diazoxide, beta-adrenergic agonists, interferons, protease inhibitors which are seen in your highly active antiretroviral therapy, antipsychotics, especially atypical antipsychotics. All of these drugs can cause drug-induced diabetes. Okay. So very, very frequently when in your COVID times we were giving steroids for the management of COVID. So a lot of diabetic patients, when you give steroids, their diabetes becomes out of control. Okay, fine. Then infections which cause diabetes includes rubella, CMV, Coxsackie. All of these can cause pancreatitis and it can cause diabetes. Okay. Then immune mediated disorders like Sif-Person syndrome. They are all antibody mediated forms of rarer forms of diabetes. Then genetic syndromes like Wolfram syndrome. We heard about Wolfram syndrome in your chapter on diabetes insipidus. So in Wolfram syndrome you have DID mode, which is your diabetes insipidus, diabetes mellitus, optic atrophy and deafness. Okay. Then Down syndrome, Turner syndrome, Friedreich's ataxia, Huntington's disease, Prader-Willi syndrome, all of these can be associated with diabetes. Lastly, never forget your gestational diabetes mellitus in your pregnancy. Okay. So this is about your whole list for your causes of diabetes. So please do not think that it's only type 1 and type 2. So this is a lot of other causes for diabetes. Okay. Now let us move on to the next type of diabetes and two terms that you should be aware of, which is your LADA and KPD. So what is this LADA? LADA stands for latent autoimmune diabetes of adults. So this stands for latent autoimmune diabetes of adults. So what are the classical features of LADA? LADA is very similar to type 1 diabetes. LADA is very similar to type 1 diabetes. Why? Because it has your anti-insulin or your anti-GAD antibodies, which are your antibodies found in type 1 diabetes. So the antibodies are positive in your LADA. Okay. But how is this latent autoimmune diabetes of adults different from your type 1 diabetes? This is because it is a very slowly progressive. This is a very slowly progressive form of type 1 DM. Okay. So this is a very slowly progressive form of type 1 diabetes. So it does not immediately present with your diabetic ketoacidosis or it does not become immediately insulin dependent. So since it is a slowly progressive form of diabetes mellitus, it becomes insulin dependent only a little later. So it does not have early insulin dependency. Early insulin dependency is not there, or it has a late insulin dependency. Okay. So does it mean that this LADA is like type 2 DM? No, it is not like type 2 DM because there are no features of insulin resistance. There are no features of insulin resistance. There are no features of insulin resistance, and usually it is a lean body habitus. Usually it is a lean body habitus. The other name for LADA is type 1.5 diabetes. It is also called as type 1.5 diabetes. So what is LADA? The characteristic features is that it is similar to type 1 DM because it has autoimmune antibodies. It has an autoimmune background, but it does not behave like type 1 DM. It does not have this explosive onset decay, sick patient, insulin dependent, no. But why is it not type 2 DM? Because there is no insulin resistance and the patient is of a lean body habitus, and this is what we call as the LADA or your type 1.5 diabetes. Now let us look at the other one. The other one is your KPD. KPD refers to ketosis prone diabetes. Okay. KPD refers to ketosis prone diabetes. The other names are Flatbush diabetes or type 1B. It's not 1.5. Type 1B diabetes. Okay. So what is this importance of ketosis prone diabetes? So as the name suggests, this is usually a type 2 diabetes patient who is very prone to diabetic ketoacidosis. Okay. So this antibodies may or may not be present. So it is not really a type 1 also. So most often it is a phenotype similar to type 2 diabetes, but they are prone to ketosis. They are prone to ketosis. Many a times type 2 DM patients they can have diabetic ketoacidosis, but it is not very frequent. It is not the presenting complaint because it is tolerated for a longer time than type 1. So in ketosis prone diabetes, they are prone to ketosis. Okay. So this is about your LADA and KPD. Now let us look at type 1 diabetes. So we will be looking at the pathogenesis now. So let us look at the pathogenesis of type 1 diabetes. So type 1 diabetes, as I had mentioned before, there is complete destruction of the beta cells. There is a complete destruction of the beta cells. So there is an absolute insulin deficiency. There is no insulin at all. And this is a completely autoimmune process. So due to unknown triggers, sometimes they have been postulated that they can be viral triggers as well. So there is a complete destruction of the beta cells and there is an absolute insulin deficiency. So in your diabetes, type 1 diabetes mellitus, there is association with other autoimmune disorders. There is association with other autoimmune disorders like what? Vitiligo, pernicious anemia, Hashimoto's thyroiditis, or even SLE. So you can see that type 1 diabetes mellitus is usually associated with other autoimmune disorders like vitiligo, pernicious anemia, Hashimoto's thyroiditis, SLE, or even celiac disease. Okay, so the crux of the pathogenesis is that this is an autoimmune process. Let us understand the temporal model of your type 1 DM. Okay, so this is your beta cell mass on the y-axis and the time in years in your x-axis. Okay, so in a patient with a genetic predisposition, sometimes there is an immunologic trigger. There is an immunologic trigger and there is damage to your beta cells. So it mainly goes through 3 stages. In your stage 1, there is first damage to the beta cell mass. In your stage 1, the amount of beta cell mass damage is less than 50%. So the preserved beta cell mass, as you can see, is more than 50%. So in your stage 1, only there are immunologic abnormalities. So the antibodies are positive. In your stage 1, antibodies are positive. Are there symptoms? No, there are no symptoms. What about the glucose levels? The glucose level is also normal in your stage 1. Then in stage 2, that is when there is a progressive impairment of insulin release. So in your stage 2, the antibodies will be positive. There is an impaired glucose tolerance, right? Impaired glucose tolerance. Okay, so only if you do a blood test, you will know that there is impaired glucose tolerance and they are not symptomatic. Then they go into your stage 3, which is your overt diabetes, where they are symptomatic, antibodies are positive and they have a full-blown diabetes, blood sugar, random values more than 200, fasting more than 126. Okay, so this is about your temporal model and this is about your pathogenesis of type 1 DM. Okay, so the basic crux of the matter in type 1 DM is that in a genetically predisposed individual, sometimes environmental triggers can be there or autoimmune triggers can be there. There is complete destruction of your beta cells. Okay, fine. So what are your genetic and environmental triggers? The genetic factors is your HLA, DR3, DR4, CTLA4, PTPN22. Environmental triggers can be viruses like Coxsackie rubella enterovirus. So in your type 1 DM, identical twins have a 40 to 70% concordance. In siblings, it is usually around 6 to 7%. Okay. So the pathophysiology, the basic problem is that there is insulitis. Okay, the basic problem is that there is insulitis. So there are antibodies produced against what? There are antibodies produced against your islet cell. So once there is antibodies produced against your islet cell, they go and damage your beta cells of the pancreas. Okay, they go and damage the beta cells of the pancreas. And how do they do that? This causes activation of your CD8 positive cytotoxic T lymphocytes. So once the CD8 positive cytotoxic T lymphocytes are activated, they infiltrate into your beta cells and cause damage. Okay, so this is about how this type 1 diabetes happens. So after understanding all of this, there is a new drug which has been come out into the market. A new drug which has been released into the market is called as your teplizumab. Teplizumab is an anti-CD3 molecule which has been in trials to say that in your stage 1 or stage 2 itself, if you inhibit this autoimmune process, you can prevent overt diabetes, prevent overt type 1 diabetes. So you can prevent overt type 1 diabetes. So which drug? Teplizumab, anti-CD3 molecule. Alright. So this is about the pathogenesis of type 1 diabetes. So now let us move on to the pathogenesis of type 2 diabetes. Now the basic feature in type 2 diabetes is that there is insulin resistance. There is insulin resistance. There is no deficiency of insulin production, but insulin is not able to act. So there is insulin resistance and there can be some abnormality in your insulin secretion as well. Identical twins, they have a 70 to 90% concordance. If both parents are diabetic, then the chances of having type 2 diabetes is up to 70%. There are some genetic defects as well in your PPAR gamma, potassium channel, campaign 10, IRS gene, etc. So there are some genetic predispositions as well. So let us understand the pathophysiology of type 2 DM. So the type 2 DM pathophysiology is something very, very interesting. Okay, so the pathophysiology of diabetes mellitus is something which is very, very interesting in your type 2 DM. So the catchword that you should remember is the ominous octet of de Fronzo. The ominous octet of de Fronzo. The ominous octet of de Fronzo basically refers to the 8 pathophysiological processes which have been defined in your pathogenesis of type 2 DM. Okay, so let us look at it one by one. The core problem in your type 2 DM is your hyperglycemia. Yes. So first, there can be an impaired incretin effect. There can be an impaired incretin effect. We had learned in your basics of diabetes that incretin is basically what? Incretin is insulin stimulator. Okay. So this basically helps in increasing the insulin release. When molecules like GLP, GIP go and bind, by the incretin effect, there is increase in the insulin release. But if this is impaired, then what happens? There is no insulin. So first pathophysiology, you can have impairment in your incretin effect. Second, what happens there? Usually your type 2 diabetes have other problems such as central obesity and metabolic syndrome. So what happens here is that there is excessive accumulation of abdominal fat. That is what we call as your central obesity. There is excessive accumulation of abdominal fat. Because of this excessive accumulation of abdominal fat, there is insulin resistance. Okay, so there is impaired uptake of your fat and there is excessive insulin resistance. So the glucose is not utilized well in your adipose tissue and there is insulin resistance. Third, there is impaired peripheral glucose uptake in your muscles. There is impaired peripheral glucose uptake in your muscle because of defects in your GLUT4 which is present in your muscle. Fourth, what happens is that we have learned that whenever there is an increased threshold, whenever the blood glucose levels are more than 180, there is a increase in the renal threshold. Once it crosses the renal threshold, the glucose gets excreted in the urine. But here what happens is that there is a fault in your glucose threshold and the glucose in fact gets reabsorbed. So the fourth mechanism is that there is a problem with the glucose excretion in the urine. There can be some amount of glucose reabsorption as well. 5. Now we have understood everything about your insulin resistance, impairment in muscle, impairment in the level of your incretin, impairment in the level of your kidney. You would be surprised to know that neurotransmitter defects are also part of your pathogenesis of type 2 DM. So there can be impairment in neurotransmitters which results in abnormal eating patterns which can contribute to diabetes. Then 6th, there is a problem at the level of the liver. So there is increased hepatic glucose output. There can be increased hepatic glucose output and there is impaired glycogen formation. So overall the net effect is that there is increased blood glucose levels. Then there can be increased glucagon and decreased insulin secretion from the pancreas. Okay, so we have looked at how there can be problem with how the insulin acts in the peripheries, but there can be problem in the pancreas as well. There is increased glucagon and impaired insulin. So what happens? The glucose levels increase. Okay, so why is this very important? Why is this ominous octet 8 pathophysiological processes of diabetes so important? Because after identification of these 8 pathophysiological processes, we have found out molecules which can be used in the treatment of diabetes, which can act in any of these 8 processes, which can act in any of these 8 processes. And also the basic rationale behind use of multi-drug therapy in diabetes is that if you combine 2 to 3 drugs, such that their mechanism of action blocks 3 or 4 of these processes. Okay, so that is why we can use multi-drug therapy in the management of type 2 diabetes. Okay, so let us look at how these drugs act on each of these processes for better understanding. So for example, SGLT2 inhibitors. So we have a sodium glucose transporter which is present in the kidney, in the PCT of the kidney. Okay, so what do these SGLT2 inhibitors do? They go and block this sodium glucose transporter in the proximal convoluted tubule and they promote glucose-urea. Okay, next let us look at DPP4 inhibitors. Where do these DPP4 inhibitors act? They act at this level 7. Okay, so in diabetes you can have increased glucagon secretion. So DPP4 is basically an enzyme which is responsible for breaking down your GLP. So when DPP4 inhibitors are given, the GLP levels will increase and it will cause your incretin effect. So it will cause insulin release. Then metformin, where does it act? Metformin acts here. So metformin basically causes what? It decreases the hepatic glucose output. Then thiazolidines, where do they act? They act at multiple places, right? They act at 2, 3, 4. Then GLP agonists, glucagon-like peptide agonists, where do they act? Again, they act at multiple places. So this is how it is very interesting how you can understand the pathophysiological process and expand it to the management in your type 2 diabetes. Okay, so that is about your ominous octet of trifrons. So this diagram is basically showing the same. So the major defect here is insulin, and insulin binds to the receptor. Once insulin binds to the receptor, it acts via the receptor tyrosine kinases and it stimulates further downstream pathways and phosphorylation happens. But in your type 2 diabetes, there is a problem with the insulin receptor, there is a resistance and the phosphorylation does not happen. Okay, and how all of this happens we have looked at here. Alright, now let us move ahead. Now let us understand how do you approach your diabetes, predominantly your type 1, type 2 and your MODY. So type 1 diabetes is usually associated with a lean body habitus and initially itself they require insulin for the management because they have a absolute insulin deficiency. In your type 2 diabetes, it is usually associated with obesity, metabolic syndrome and initially they do not require insulin. There can be a history of hypertension, cardiovascular diseases. Type 1 diabetes seen in younger individuals, type 2 diabetes seen in older age group, but nowadays the trend has changed. Type 2 diabetes can be seen in younger individuals as well. Then, family history of autoimmune diseases are more common in your type 1 diabetes. How do you diagnose? When you look at your fasting C-peptide levels, they are decreased in type 1 diabetes and antibodies like your anti-insulin antibodies or your anti-GAD65 antibodies are present in your type 1 which is absent in your type 2 diabetes. Okay, so this is about how you will approach your type 1 and type 2. Now let us look at this group of disorders what we call as maturity onset diabetes of the young or MODY. So what are the classical features of MODY? So MODY is basically characterized by diabetes mellitus that arises at an age of less than 25 years. Okay, fine. And this has a multi-generational history. There is a multi-generational history of diabetes. Okay. Apart from this, this is mainly occurring due to what? It is a type of monogenic diabetes. It is a type of monogenic diabetes where there are genetic defects in these multiple enzymes, and based on that it can be classified into the following types. So the most common type of MODY, is your MODY type 3, where there is a deficiency of HNF1 alpha. Okay, HNF basically stands for hepatocyte nuclear transcription factor, and these are factors involved in islet cell development. So if there is a damage to that, there is no islet cell development. Okay, most common type of MODY is your MODY type 3, and this is sulfonylurea responsive. The second most common type of MODY is your MODY type 2, where there is a deficiency of your glucokinase enzyme, and this is also responsive to OHAs. So MODY type 3 is the most common, and the good news is it's responsive to sulfonylureas. Then MODY type 1 is due to deficiency of HNF4 alpha. This is associated with a very early onset diabetes. Then MODY type 4 is IPF, MODY type 5 is HNF1 beta. Okay. The characteristic feature of MODY type 5 is that it has associations with renal cysts, and end-stage renal failure risk is also high, and it is highly insulin dependent. So depending on which type of MODY you have, you may be insulin dependent or you may be sulfonylurea responsive. MODY type 6 is due to a problem with your neuro-D1 gene, and it has a lot of CNS manifestations as well. Clear? So this is about your MODY. So with this, we are coming to the end of our session on your etiology, pathogenesis and classification of diabetes mellitus. In the next session, we will be looking at your management and complications of diabetes. Thank you.